Good afternoon. It's a pleasure on behalf of my collaborators to present this trial. The disclosures are shown on this slide. This study was sponsored by Novartis. There's a clear unmet need for treatment in premenopausal patients with hormone receptor positive and HER2 negative advanced breast cancer, and this accounts for about 20% of patients diagnosed in the U.S., and it may even be higher in other parts of the country. Younger women tend to have a distinct biology, more aggressive features, and may actually experience a higher risk of progression and death than older patients. The endocrine therapy that's typically recommended for premenopausal patients involves ovarian suppression, but ultimately resistance does develop in virtually all cases. Investigation has not focused much on this subgroup. We do know that in postmenopausal patients, the addition of ribociclib, a CDK4/6 inhibitor, to letrozole does significantly prolong progression-free survival, as demonstrated earlier in the MONALEESA-2 trial. So this trial, the MONALEESA-7, is the first phase 3 trial that is investigating CDK4/6 inhibitors specifically in a pre- or perimenopausal population of patients with advanced breast cancer. The preclinical activity of ribociclib and both letrozole and tamoxifen has been demonstrated in preclinical models. This is a patient-derived xenograft model that shows that the combination of two hormonal agents and ribociclib is superior than either agent alone. So this is the schema of the MONALEESA trial. This was a randomized phase 3 trial. Pre- and perimenopausal patients were randomized 1-to-1 to receive either ribociclib or placebo added to the endocrine backbone of goserelin and either tamoxifen or a nonsteroidal aromatase inhibitor. Randomization was stratified by the presence of liver-lung metastases, prior chemotherapy in the advanced setting, and the endocrine partner chosen, either tamoxifen or aromatase inhibitor. The primary endpoint was progression-free survival as judged by the local investigators, as well as overall survival, response rate, clinical benefit rate, safety, and patient-related outcomes. The study was adequately powered to detect a 33% improvement in progression-free survival. Sample size of 660 patients was required, and the primary analysis planned after 329 progression events. So in more detail, I have the key inclusion criteria. So pre- and perimenopausal was defined by NCCN guidelines. Patients had to have measurable disease, an adequate performance status, one or no lines of chemotherapy for advanced disease, and then hormonal therapy could be either an aromatase inhibitor of tamoxifen if a patient had not been exposed in the last year, but if a patient had been exposed to either of these in the last year, it had to be the alternate drug. And the exclusion criteria are shown on the right. 672 patients were randomized between December 2014 and August 2016. The median follow-up at the time of cutoff was 19.2 months. About a quarter of patients ended up being on tamoxifen and the remainder on aromatase inhibitor. All of the patients were included in the full analysis and safety set. The patient demographics and characteristics are shown here. Well balanced between the arms. As expected, the median age was low, 43 and 45, as this was a premenopausal population. 30% of the patients were of Asian ethnicity, and 40% presented with de novo metastatic breast cancer. Patient disposition is shown here. The main reason for discontinuation was due to progression of disease, and only 3% of patients discontinued due to adverse event in both arms, roughly 3%. So here are the main data, a primary endpoint of progression-free survival. This showed a highly statistical difference with a hazard rate of 0.553 and translating into 13-month progression-free survival on the placebo arm and 23.8 on the ribociclib arm. If you break it down by the endocrine partner, and again, remember this is the first time tamoxifen has been tested in this setting, the hazard rates are similar between the two. The supportive analysis, which is progression-free survival, centrally read by an independent review committee, 40% of the patients chosen randomly, also shows a highly statistical significant difference in the PFS with, in this case, a hazard ratio of 0.427. And if you look at this forest plot, looking at the benefit among the key subgroups, you'll see that the benefits are similar in all of the subgroups. There's none that stands out, whether it's the endocrine therapy partner, as I showed, or age, ECOG, performance status, distribution of disease, or a disease-free interval. The secondary endpoints also showed significant differences, response rate of 41% among all patients in the ribociclib arm compared to 30% in the control arm, and slightly larger numbers in the subset of patients with measurable disease. Clinical benefit rate was also significantly improved with ribociclib. And the overall survival data at this point are not mature and will be presented later. In terms of looking at how much of the drug was able to be given to patients with dose reductions and things of that nature, in the ribociclib arm, 94% of the intended drug delivery of ribociclib was given, and it was 100% in the placebo arm. And most of the dose interruptions and reductions were due to adverse events. About 35% of patients had to have a dose reduction, and the majority of those had one single dose reduction. Hematologic side effects are shown here. The grade 4 neutropenia rate was 10% in the ribociclib arm, but generally not accompanied by symptoms. In fact, febrile neutropenia was only seen in 2.1% of patients on this arm. Non-hematologic adverse events are shown here, and primarily these reflect adverse events typically associated with tamoxifen or aromatase inhibitor therapy. Grade 3 and 4 adverse events were infrequent and similar among both arms. There was prolongation of the QT interval in this study. About 7% of patients experienced one of 480 milliseconds or more. However, treatment was discontinued rarely. Only one patient in the ribociclib arm and actually 2 patients in the placebo arm due to prolonged QT intervals. And these were not associated with any clinical symptoms or clinical events or any arrhythmias. Patient-reported outcomes using a quality of life tool showed that the time to deterioration was actually improved or delayed with the ribociclib arm, and this was statistically significant. And in addition, a pain score that was measured showed a clinically meaningful improvement in the pain score as early as 8 weeks on therapy, and this was maintained over time. So in conclusion, MONALEESA-7 is the first phase 3 study dedicated to the evaluation of CDK4/6 inhibition as frontline therapy, specifically for premenopausal patients. PFS was significantly improved with the addition of ribociclib, extended from 13 months to 23.8 months with a hazard ratio of 0.553, highly significant. And treatment benefit was seen across all subgroups and also regardless of endocrine partner, either tamoxifen or aromatase inhibitors. Ribociclib combinations demonstrated a predictable toxicity effect that has been described earlier. And also with quality of life, a clinically meaningful delay in deterioration was seen in the ribociclib arm. So to summarize, this is the first dedicated trial for premenopausal patients showing that ribociclib combined with either tamoxifen or an aromatase inhibitor given with ovarian suppression with goserelin does improve outcomes and is an important potential new treatment option for premenopausal patients, a group that is very understudied. I want to acknowledge the patients and families who participated in the trial foremost, and also members of the steering committee, all of the investigators, the staff at all of the sites, and the data monitoring committee. This study was sponsored and funded by Novartis, and as you can see on the right side, sites from across the globe contributed to enrollment. Thank you.